We are live now.
Yes.
Good evening, esteemed faculty members and all the delegates and participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for this webinar. And today we are back with our series Med Mocha Meetup, Season 1 and Session 6. And today's topic is anemia and pregnancy. So let me introduce the organizer of this webinar, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is consultant obstetrician, gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. So I welcome you, ma'am, and I request you to give the welcome address.
Yeah. Thank you. Thank you, Sahiti, and thank you, Shield Pharma, for constantly providing the platform for our this academic discussions. So, friends, today with me, my very dear friend, a very knowledgeable person, Professor Dr. Rajeshri Katke is with me. I know all of you have seen us together in so many webinars, and luckily, by the grace of the God, or I can say my Mata Rani blessings, all the webinars has gone super hit. So I am really thankful to dear Rajeshri. Friends, I know Rajeshri's schedule is very, very busy, but she is also very keen for the academics like me. मतलब वो बोलते हैं ना हम दोनों की दोस्ती इसीलिए शायद बहुत अच्छी है. She is also very much passionate about the knowledge sharing. So when I requested her that today we are going to have to discuss the regarding the anemia, because 2 years back when me and Rajeshri had done one show on the Pundit show, which was very popular at the Corona time, that show has got the maximum highest rating when I had done with the Rajeshri, the anemia in pregnancy. So we know every day in our OPD we are getting the patients of anemia from adolescent to menopausal age group. So today we are focusing mainly on the anemia in pregnancy, how to deal with. There are a lot of complications. There are a lot of iron compounds are coming daily in the market. Recently, we are seeing every day one or the other person is coming to meet us with the FCM injections. So how good that we can give the tablets, and what about the different kind of the injections, that all we are going to discuss with us with my very dear friend Dr. Rajeshri. A very, very warm welcome to you, dear Rajeshri. Sahiti, may I request you please do the formal introduction of madam?
Yes, ma'am. So let me introduce the speaker of this webinar, Dr. Rajeshri ma'am. Ma'am is the professor and head of the unit OBGY, ex-superintendent of Kama and Albles Hospitals, Mumbai. Ma'am is the renowned obstetrician and gynecologist and surgeon par excellence. Ma'am is the medical undergraduate and postgraduate teacher for more than 2 decades, researcher, editorial and author, associate member of RCOG. Ma'am has more than 100 plus publications in national and international journals, and also 330 plus citations. So around 150 papers were presented by students under ma'am's guidance. Ma'am has written many book chapters. So I hand over the session to you, ma'am.
Yes, yes. Thank you so much. Saiti, once again, please display the madam CV. Once again, please.
Yeah, yes, ma'am.
Yeah, because few things I think has to be highlighted. Uh, Related to this, she has received a world record of London Committee certificate. That is really remarkable. Mumbai Achievers Award, Vagini Puraskar, Lokmat Women Achievers Award 2021. Besides, there's many accolades with her. A very, very warm welcome to you, dear Rajeshri. Yes, you can stop sharing now. Thank you, dear. Yeah. Sahiti, may I request you please make the spotlight on me and Rajeshri.
Sure, ma'am.
So because this, yeah, thank you so much.
Great.
So, because today our program is not any PPT based, today we are going to discuss the what are the practical problems we are getting, and this is a question answer discussion. So now, without wasting time, Dr. Rajeshri, my first
Yes.
question to you, as we are seeing lot of patients of anemia in our OPD, we know the iron deficiency, B12 deficiency, folic acid deficiency, all are the causes. So, will you please, because this program has been seen by from the postgraduates up to the senior consultants.
Yes,
So this
yes.
is this is my request for the sake of everyone. Can you little bit elaborate about the classification of anemia? Huh.
See, anemia, the main important thing is there is deficiency, and that is the most commonest is the nutritional deficiency. As you said, iron deficiency, folate, vitamin B12 deficiency, that is the one thing. Second thing is that during pregnancy, if there are multiple pregnancies, or multiple pregnancy, and there is a short duration of the pregnancy, that is, this is why I am highlighting, because there has to be a minimum 2 years time to get replenish the body stores of the iron and the calcium to get pregnant, but frequently grand multiparity that will give rise to the more common anemia. And we are having nutritional deficiencies. Hemoglobinopathies are there, like thalassemia, sickle cell anemia, and autoimmune this thing. Then systemic infection, that is the most important thing, like bacterial infection, viral sometimes during pregnancy, and tuberculosis. These are like that. And the commonest and the most important cause in our country is that basically the hookworm infestations. That is the one thing where there will be a chronic acute blood losses as hemorrhages in pregnancy, or the chronic blood losses like a chronic infections, autoimmune disorders, and the parasitic infestations, helminthic, worm infestations, chronic malaria, filaria. So these are the things. And then comes to the like ITPs, and then systemic disorders, platelet disorders. These are the things which are practically we can go ahead with that. And but the most commonly we are seeing is the nutritional deficiencies in that.
Yeah, yeah,
Yes.
very true. Very nicely you have explained. So, friends, as we all are aware, as Dr. Rajeshri has also just mentioned, the nutritional deficiency is very, very common. We are seeing the girls are coming, the adolescent girls are also coming to us, or the just now the menarche has started and they started their menses. Their moms are getting that, ma'am, she is having lot of bleeding. Her, though I am giving her good diet, still her hemoglobin is not coming up. So, what are the medications and what are the pros and cons? So, basically, yes, we all advise about the nutritional corrections. So, yes, of course, we will discuss that also. Dr. Rajeshri, as we all know, we advise. Just a second, I received one question on the YouTube. Yeah. Uh, okay. Wow. See, this is a very nice compliment, Dr. Rajeshri.
Yes.
This is from Dr. Shamma Akhtar from Dhaka. Huh? She is writing, Ritu ma'am and Rajeshri ma'am, good to see your Jugal Bandi. Huh?
Thank you, thank you.
Huh?
So nice.
So, yeah. And this is very
I
nice
love you.
topic. Yeah, this
Hmm.
is very nice topic. And of course, we need many more clarifications on this related to iron injection. Of course, we
Yes,
are going to
yes,
discuss
yes.
that
We are going.
also. We'll discuss later on. So, as our topic of discussion is towards the anemia in pregnancy. So, we all know about the IUGR and the related to problems in the delivery. So, Dr. Rajeshri, my request to you, please classify what are the effects on the pregnancy by this anemia.
See, effect on the pregnancy is with on the mother and the fetus. Mother, we know that if she is priorly anemic also, so she will have, because the physiology of pregnancy is very important in that, where there will be hemodilation or physiological anemia. And after that also the demands is increasing, and if she has a depleted stores, then definitely she will be prone to the chronic the anemia during pregnancy, pre-eclampsia, eclampsia, then abruption. These are the things which is coming it up. If there is a immunity is reduced, or there is protein deficiency, then she will have a edema, swelling, then infection. So these are the things with her during pregnancy. And in delivery also, because the basically the myoglobin is very less, so they will have a first stage of the labor, second stage of the labor, sometimes slow progress of the labor, or there will be a fluid overload in the body. So in a second after delivery of the fetus, she may go into a cardiac failure or the pulmonary edema, pulmonary congestion. So these are the things with the severity of the anemia. About the fetus is a very important. Fetus is always parasitic person. So it distracts, and fetal hemoglobin has a dissociation curve to the left. So basically, they have a strong affinity to the hemoglobin. So unless there is a severe anemia, the fetus will not get the anemic. But now one important thing, Ritu, is that see this iron B12 and the folic acid, this is very much required for the brain development of the fetus. So cognitive development of the fetus, it is very important in that. So we are coming with the, all the national programs, they are coming with the iron is the folic acid, and then if it is required, the B12 also. So these are the things. Either it will be, she will go into a preterm labor, PRM, prematurity, puerperal sepsis. So these are the things where you can get the sort of complications. Yes.
Yeah, very true. Thank you. Dr. Rajeshri, meanwhile, I have received 3 questions now. These all are related to medical management. See,
Yes.
one doctor has joined from Satara. Huh?
Yes.
She has only mentioned Dr. KN. Full name is not mentioned here.
Okay.
Doctor, Madam, will you, he or she, I am not aware, sorry. Huh?
Okay.
So, Madam, will you please focus today's discussion on the different kind of the iron preparations and injections? Yes, of course, we are going to start that discussion only.
Okay.
So one more question, Dr. Rajeshri, that is Dr. S.K. Sinha, huh? Joined from Muzaffarpur. Madam, we want to know about the use of the iron injections and the side effects. Okay. And yeah. So we will start with this now
Medical.
related to medical management, Dr. Rajeshri. So, according to you, that which salts are good and which salt is having a maximum iron. So, please start giving some focus on this.
Okay. So see, iron can be given with the 3. One is the dietary source, which is very important, nutritional, that we should not forget. So in that, the heme form of the iron and non-heme, vegetable sources. So, spinach is there, green vegetables is there, dates is there, raisins are there, jaggery is there. So these are the things one should include in that, okay? Almonds and all those things. Then comes to the non-heme, if they have a fish, meat, liver, the muscles, chicken and all they do have in that. Okay. The second important thing is that why I am highlighting this, because this will come again with the salt preparation, is that so basically there is a absorption with the ferrous form when it converted from the ferric to the ferrous form. So very important. So we should, what are the things which will highlight for the either the iron tablets or the iron source in the nutrition. So it should be taken empty stomach. That is one thing. Acidic will increase the absorption of that. Then it should not be combined with the coffee and tea. Tannins are there. So these are the things one should take care of that. Non-heme source of the iron, they have a maximum absorption and mainly the bioavailability in that. Okay. Then we will come to the what are the oral form of the iron. So in that everybody is interested in that. Then there are the various salts like a ferrous sulfate, fumarate is there, then ascorbate is there, hydrate is there. There are so many of these things. Believe me, we cannot say this is the only one single salt is there. What suits to them is very important, because I have some patients which has been very much suited with the ferrous sulfate also. Okay. In some of in the salts, they says that there is a less of the sustained release, or the entry coated tablets are there. So that is there because they will release the iron slowly. That is one thing. Second thing is that because of the coating, they are not coming with the gastric mucosa directly. So there will be a less of the ulceration. That is what the people says in that. So in that we have I won't take the brand names here, but so these are the compounds where you will get the some of the benefits of that. But again, you have to prescribe the patient and see that how she feels in that. So that is the thing where you can say in the government we are giving with the ferrous sulfate. Then in most of the people, they say that there is a more absorption with the ferrous ascorbate. When the iron is combined with the vitamin C, there is a maximum absorption in that. Don't take iron with the calcium, because that oxalates and all that reduce the absorption of the iron, this thing. Then,
Yeah.
then one theory is of that ionic ions, ionic bioions and all these ions. So in that, it was quite popular in between. I don't want to take the brand names of that, but after that, I think it has not come up. It has not picked up the things very easily with the patients.
Yeah. So thank you, Dr.
Whatever
Rajeshri. Yeah.
whatever
Huh.
salts your patients they get suited, that is there in that. So some of the for the salts people say that it is very good and all those things. So in that you have to see the patient's compliance, suitability, cost benefit, and then if it is required you can go ahead with the higher salts also, or the newer ones also.
Yeah. So very nicely you have explained whether the ferrous ascorbate, whether the ferrous sulfate, whether the ferrous
Citrate,
fumarate,
citrate,
yeah,
fumarate,
yeah,
all these
yeah,
are there.
fumarate, ferrous succinate, huh? So,
Correct.
yeah, so there are so many preparations are available. Of course, the daily recommended dose for the elemental iron we have to keep in mind, as Dr. Rajeshri has very clearly explained. Yes, the
During
different,
pregnancy, we should keep, with the 100 milligram of the elemental iron,
elemental,
but
yeah,
normally they are saying with the 60 milligram of the
yeah,
iron, but we should be with the folic acid. So folate will be around, you can say 500 microgram or 200 microgram in that. But nowadays we are getting a vitamin B12 deficiency is much more, and
much
vitamin D
more,
deficiencies is much more.
much
And
more.
especially cases of the infertility who are on the metformin. So they are having a lots of the
B12,
B12 deficiency. So
yeah,
do the serum B12 levels of that, and you can supplement with the this with 500 microgram or 1000 microgram, that they can be take, because in India most of the peoples they are there with a vegetarian diet. So B12 it is more with the fish, eggs, and iron, milk products, and all those things. I would like to give a very simple example. There is a very high influencing judiciary I mean, she was there.
uh-huh.
Was on the
Okay,
dais, and then she came with me to me to take this thing, because she was having a lots of this thing, disturbances, cognitive and all those things, shown by many people, and even the physician has also seen her. And but I said no, I will do again 2 3 tests on that. So I did a serum folate, RBC folate, serum B12, and vitamin D3. The serum B12 has gone so much of the down, and the folate has also gone down in that. So we have to give a injections, supplements for her, and then after that she has been regained. So what it happens is that most of the times we ignore the things, but give a very, you ask the patient if she is saying nowadays, young girls there, there is a, tingling, numbness is there. So just check for the serum B12, and with that also you can check with the serum folate level also, because the
true.
whole thing has been changed now. The epidemiology is changing and everything is being changing.
Very true, very true. Yeah. Thank you so much for this. So, as Dr. Rajeshri has clearly mentioned about the this different iron preparations and the how we have to advise the patient not to take with the calcium and preferably to take with the some orange juice or something or with the orange, so that will increases, or simple lemon water that will increases the iron absorption, or to cook in the iron utensils. So that is also good. Huh? These days, a lot of platforms are selling lot of iron utensils. These are is in the great demand. Today only, na Rajeshri, I
Yes.
have one girl of from 24 years, and she came to me for this AUB. Huh? So I told her, yes, you are looking very anemic. Huh? Ma'am, how can I be anemic? I have purchased the iron utensils for this platform, from that platform, and I am cooking, and my maid is cooking all this with the iron utensils. Huh? So when I asked her about the detail, yeah, she given me the that she is taking
एकदम
uh,
छान
please please mute everyone else.
Somebody has
yeah. Dr. Usha, will you please mute your mic? Dr. Usha?
Yes.
If I am able to mute, I will mute her. Sahiti, will you please mute her?
Dr. Usha.
She is not listening. Sahiti,
Her attention is there.
Sahiti, can you mute her? No, I am not able to mute her.
Oh my God.
Right click on her name.
Her name is here only.
Right click.
Dr. Usha.
Now, no, muted. So now coming to because our show is of half an hour and only 5-6 minutes are left. So now,
injectable
yeah.
Thing is that whenever you explain to the patient that she will get iron staining of these tools is there, and compliance with the iron salt is very important for the oral, because there are 2-3 things. One is that iron, if she is taking iron, whether it is the absorption is happening or not, that depends upon the bioavailability of her. And the second important thing is that if any malabsorption syndrome, if she has, or intestinal problem is there, so we have to be very clear in that, because we give iron tablets and sometimes they don't get improved in that. Then you can watch for the reti count or the hemoglobin, rise in the hemoglobin. So it is very important. The second important thing here I would like to highlight is that whenever in such cases nowadays, even the thalassemia or the hemoglobinopathies are also in there in that. So whenever you are giving, if the patients you have given the iron, she is not getting improved, or if there is if the serum iron or the hemoglobin is MCV is low, and MCH is there, and still, if the patient is complaining in that, so suspect of the thalassemia also. Serum ferritin is very important. Serum ferritin less than 30 microgram per liter is very important. That is the, one landmark in that. So in iron deficiency anemia, treating anemia is very cheaper than investigating the anemia. But in some of the cases, if we miss about the thalassemia, and if you give on the ions, and then they will go into the iron hemoglobin. Okay. So then the injectable, everybody wants to know about the injectable.
Yes, everybody wants to know about the injectable.
Injectable, in our era, there was only for the intramuscular. In that, we used to use a deep intramuscular jet technique, iron dextran, injectopper, and all this. So nowadays we are not going for that, but there are few people, those who doesn't want to go for the IV, they still ask for the IM. I mean, very rarely, but it is not, outdated nowadays. Some people, they want, to go for the deep. So it has to be given for the deep intramuscular. Now comes to the IV iron injections in that. So in iron sucrose carboxymaltase is there. And in this, it is to be very clear in that you have to see further. I mean, now I was on the panel with the hematologist on this only. And they also says that you should do the serum ferritin when you are giving into this thing. Because by chance, if there is stores are full, and if we give so much of the things, if she has a mild thalassemia and all, then it will be a problem in that. So iron sucrose is the one where you can see for that. So basically either 100 milligram. I feel that you should go either 50 or 100 milligram of that, and we should give it very slowly. That is the thing. Why I'm telling you, because there are some cases where they have a severe anaphylactic reactions in that. So you have to be very careful. For 90% patient, it doesn't happen. I will tell you one thing. About 2 months back, one of our anesthetic friends, she was not from Mumbai, but from this thing, and very lightly they gave her, and she went into a severe anaphylaxis, and they could revive because she was in this thing stand by the anesthetist and all. So I'm not saying anything, but basically, whenever the iron injections you are giving, just ask her she has any history of any reactions or sensitivities there. This is very important. Take a consent. It is always better, It is not from the book, but I'm telling you out of the experiences in that. And start with slowly, sometimes they have the ability, to push it through the IV and all those. No, don't go for IV. Go it with slowly with the IV infusion. Put it around, suppose for example, 100 milligram. You have to calculate the dose of that. What is the targeted and what is the requirement of the hemoglobin, and then with the body weight in that. So if you calculate, suppose if you want to give her, then put with 100 milligram in 100 ml of the normal saline, and then you put it the drip and let it go with slowly in that. It should run around 20 to 30 minutes. Is this first 10 minutes slowly? Watch the pulse. Important. Watch any rash on the body. Don't put it and go away in that, because the first important thing is that it will be, the patients will have the rash or the breathlessness and all those things. So this is very important in that. I was on one of the case where I think there was a severe anaphylaxis and fatality in that actually. So carboxymaltose, this says, and the delta on the molecular weight of the iron is very important in that. And the carboxymaltose, this is they are having, less reactions in this, but some people, they do prefer with the iron sucrose also in that. So this is
Right.
about the
Yes.
iron.
Yes. Yes.
But still, I will say that because she was not pregnant, but the doctor, she had a very big this thing. So what it happens in that, whenever you give there is either itching at the tingling at the mouth, or there will be a rash on that. There will be a sudden hypotension in that. Watch the pulse in that. See the BP in, and assure the patient. And suppose if you feel that in a post 5-10 minutes there is a reaction, stop it and keep ready with the, all the essential emergency drug train. This is very
Right.
important,
Very
because
true. Very.
if suppose the anaphylaxis sets in, and if we rush for the, where is the adrenaline, where is the nor, where is the terbutaline, and where is the things, then that should not be. Nothing happens in a 99% cases, but in 1% cases also we should not take risks, because that 1% is taxing one patient's life, So mortality, morbidity, that for we should work for that 1% for 100 patients, not for that
Right.
90. So don't take it lightly, because there are reactions with some of the this thing. This, so I told you, non-pregnant, one of my colleague friend only, she got that, and she was luckily, she said she has come out of it. Otherwise, she was already like a gone. This thing. So these are the things. So serum ferritin is very important in that. If you are giving the injections in that, then second important thing is that just see for that what the real cause of this. I don't want to go in detail of what is the hemoglobin level, MCV level, and all those things, because everybody knows in these things. So this is
Yeah.
the thing. Should go
Yeah.
ahead with that. Then
Yeah.
another one thing is that there is a concept that, serum ferritin level, we have seen in a COVID that it increases with the inflammation also. So if you are suspecting that also, then do a C-reactive protein in that, or the interleukin 6 and all. But I'm talking about the rare of the cases where, but this is an academic platform, so we can see about this also in that. And in a cases where you are giving it and you feel that there is a deficiency of the iron and all, look for the good peripheral smear is very important in that. See for there is a megaloblastic, Havel jolly bodies are there. There is target cells are there. So hemolytic RBCs are there. That will give the exactly idea about in microcytic, hypochromic, macrocytic. These are the things where you can see that. Again, one important thing I would like to say in that practical approach is that it's what happens with because we are getting most of the vitamin B12 deficiency. B12 is very important, with the synthesis of the
mostly the DNA. So what happens that nuclear part, it gets enlarged, but the RNA synthesis with the cytoplasm. So cytoplasm, it will be remain like that, but there will be disproportionate in between the nuclear and the cytoplasmic ratio. So in that, if suppose on the peripheral smear you can diagnose, you don't have to go for the other further investigations in that. But if you give only iron and not for the, if we don't treat with the folic acid, which is required for their synthesis of the RBCs or the erythropoiesis or the, for the DNA working, then it becomes very difficult. So with the iron, so there we should supplement with the, either you should give with the folic acid, because it is being in a combination in a government packs also. We are giving about the 100 tablets where iron and the folic acid, and then after that also we are giving with the 100. The same with the even the private practices where we are working on that, and most of the doctors, they are aware of this. Just like for the contraception, there is a cafeteria approach. So it's like with the iron salts also, it is like a different source, because practically I'm talking about we have given the very finest iron salts where for the some of the patients, but it has not been suited in that. So basically you change it and see for that also.
Very true, very true. So thank you, Dr. Rajesh, for explaining such this in great detail. So friends, if there are any questions, you can ask now, as the time of show is already over. And thank you for discussing for these all practical points. The program has been going live on the YouTube. Those want to see those who have missed
And
the earlier
with
discussion
the,
can.
we can
Huh.
talk about the two things in that. One is the blood transfusion, where there is a severe anemia. You can go for the blood transfusion at the third trimester or the late third, or the during deliveries also. So this is very important. With the second stage, delivery cut short the second stage of the labor. That is very important. See, talking it is very easy for this, but it is like a nightmare when severe anemia to deliver. So patient suddenly goes with the pulmonary edema and all those things. So keep Lasix ready once the delivery of the baby is there. Don't give methargine, because these are the very simple things. But with that, with the vasoconstriction, it will refresh all of the extracellular fluid to the intracellular, and they will be increase into the cardiac load in that. Use very nicely either the pitocin or then carboprost you can use in that. And we have to be very careful in that, and don't use very high forceps and all in that, because she is anemic, and traumatic delivery will again give problems to her. बाप रे, रितु
या
क्या हो गया?
बस नहीं नहीं नहीं, मेरे में यहाँ पे कुछ ये हो रहा है, ब्लरिंग हो रहा है बार बार। नेट का कुछ प्रॉब्लम हो रहा है, बार बार ब्लर हो रहा है, उसको मैं बार बार
हाँ,
ठीक करना चाह रही हूँ, है ना। हाँ,
वो नेट
मेरे
से नहीं
मेरे
कर रहा।
आगे ना ब्लर हो जा रहा है बार बार। हाँ
और
हाँ
एक दो पॉइंट बोलते हैं. वन इज फॉर द
हाँ हाँ
thalassemia, where you
हाँ हाँ
can go ahead
हाँ
with the preconceptional counseling is very important in that. Then
हाँ
you go for the see, do the hemoglobin spectrum, see for the husband's hemoglobin in that also. Don't miss any thalassemia major is in that. And then we can because to diagnose it is very important, because we should not overload in that. And one important thing I would like to say that for the thalassemia, don't overload with the iron. See for the serum ferritin. If there is a deficiency, give for the iron. If there is overload of the iron is there, then go for the chelating agent. This for example, then DFO is there. Okay. Then
yeah
TFPO is there. So these are the things where you can use the chelating agent, but not at the first trimester. It should go for the second and third trimester, and you can stop also before that. But what the people
correct
they are saying is that in the preconceptional, it is very important in that you should see three important things. One is a thyroid dysfunction is there, or the second means endocrinological, and second important thing is that glycosylated hemoglobin, because they are very prone to go for the diabetic condition in that. And with the serum ferritin levels, do a overload is there, do chelating for that. Keep it the serum stores and the serum iron in a normal range, then she can become a pregnant, and then you can assess for the her status for the cardiovascular status. Then all the things are there, liver, cardiovascular, then bone marrow, this bone thing, So these are the things we should take care. Why I'm highlighting? Because now with the investigations, we are getting most of the patients with the thalassemia minor and the major. There was one case where we have given more than around 500 blood in a pregnancy. There was one case with us who has come as a thalassemia major with central placenta previa. Around 20 weeks she came. It's a long story of around in a year of maybe a 2000. And that patient, it was very difficult to not to go terminate or to do the things. So it was very difficult. We admitted her. She used to take the blood transfusion every whenever it is required, but it was more in that. So here in a year, she got around 500 of the blood transfusion in that. She was central placenta previa. We have delivered. We published also in that. So basically, those times we had a very good hematological thalassemia unit at St. George's Hospital. Dr. Jaju was there. So these are the things where rarely it comes to you, but we should know if it comes to us in that. So counseling is very important in that.
Yeah,
And
yeah,
generally the adolescent girls, if they are coming, they are diagnosed, then we can say about to the parents about the marriage and the fertility aspects of that.
Before
And
we wind up,
sickle
Dr.
cell,
Rajeshri,
sickle cell, so we don't have
yes,
much
yes,
of
yeah,
that. But in
yeah,
the
same.
sickle cell disease, it is very important that always with the anemia, if it is not responding of this thing, or if you consider about the hemoglobinopathy, or there is a genetic thing is there, because these are the with the some of them thalassemia, it is a quantitative. Globin chain synthesis. This is the qualitative where you can have a hemoglobin S, sickle hemoglobin AS like that. So where what it happens with that in a hypoxic condition, there is a sequestration of the RBCs, and when they go through the capillaries, they get ruptured in that, and then they will have all these things. But during pregnancy, please take care of her during labor. If the patient has a sickle cell anemia, then she should not go to the vaso-occlusive phenomenon, where you will get a sudden vasospasm, acute chest syndrome will be there, or there will be a hemorrhage, there will be leg ulcers and all this thing, anemia will be there, swelling will be there. So these are the things. So basically, admit her, hydrate her. So in late stages, you need a steroids for their cure of the infection, give the higher antibiotics, and deliver in a higher centers, because in our Maharashtra also, there are the belts like, Nagpur and all, they have a sickle cell wards in that, because it is very common in that. But as a migration, these patients, they can come to us also. So we have to be very careful in that. So this is about we have concluded about in a short time, because your time is very half hour time. But hemoglobinopathy, practical tips, the deficiency anemia, and the main is the iron deficiency, how to treat, what are the complications, and how to go ahead during pregnancy, during labor. And एक ही रह गया अभी purpurium. In purpurium patient, they should mobilize more. Don't use of the copper tea as a, let them go with the barrier methods, or the pills if they are getting. Don't put a copper tea, because with the copper tea, if she starts bleeding, she will be again anemic with that. And if she is multi, then when she is fit, go for the permanent sterilization, either she or he. Namaskar.
True.
So I think in short, it is a very short time, but I think we have touched every of that.
I am visible on the screen. I am visible on the screen.
You are visible on the screen.
Totally blurred.
Yeah. So eyes was looking, I thought you were like sleeping eyes, but it is a blur.
Because the screen is totally getting blurred in between.
Yes,
now?
mine was also in the beginning like that.
So yeah, now it's visible. Now it's clear, because I think net is fluctuating here.
Yes, here also.
Yeah. So thank you, Dr. Rajeshri. Let me once check the questions in
Please
the
check.
YouTube. Dr. Rajeshri, there is one question. The doctor has joined from कांचीपुरम. अभी पूरा नाम नहीं लिखते ना, तो मुझे अभी ये नहीं समझ रहा है ना.
कोई बात नहीं.
हाँ, इनका नाम है डॉक्टर सेजे चित्रा. डॉक्टर सेजे चित्रा फ्रॉम कांचीपुरम. द क्वेश्चन इज कि मैम, just now you have mentioned about this not to use this IUCD and only the barrier contraceptive methods.
Then
So
OC
how?
pills they can use that. OC pills they can use. And
What the question? What the question? I'm just telling you,
yes.
And so, acha, this question means is like that only. How to counsel the patient regarding the use of the OCPs in the anemia. I'm not getting the question.
ठीक है, I got the question. I got the
हाँ,
question. See, what is the contraception?
हाँ,
Basically, suppose why I said is that she is anemic, you know, and we are
हाँ,
treating the anemia. Anemia treating is, I would like to tell one thing is that treating anemia means not increasing the hemoglobin. After
हाँ,
treatment, we should replenish the stores, you know. So for
हाँ,
that, again, you have to give for a 3 months or 3 months or 6 months, depending upon her deficiency. And during
yeah.
lactation also, there will be a demand from the fetus and with the body also in that. Suppose in that, if suppose that property doesn't suit to her, then you can, it is of no use. Injection antara after delivery of anemia patient is possible. So injectable antara is there, then pills are there, progesterone only pills are there, barrier methods if they want to use, they can use that. If she's grand multi, if she becomes fit, then you do a permanent sterilization, or otherwise you can ask for the husband for a non-scalpel vasectomy also in that. Because the most important thing is why I am highlighting the contraception. She should not become again pregnant and she should come for either MTP or the next delivery. That is what my concept is there. And always give these iron supplementations till she is lactating also, until she gets replenishment of the stores also in that. So it depends upon her deficiency anyway in that.
See, see, the doctors are so attentive, those who are listening, huh? See, there is one question. Actually, doctors mentioned not to take my name, so I'm not taking, huh? Are you talking about the Antra? So, so yes, friends, Antra for the DMPA we are getting in
DMPA
India.
we are again getting
हाँ,
free national program है अपना.
हाँ. So the doctor is joined. अभी लिख रहे हो, next line में लिख रहे हो, ma'am, you can tell from where. So doctor has joined all the way from Kuwait.
Okay.
तो देखो, अभी he or she, I'm sorry, I'm not able to understand. Dr. Sheikh only it's mentioned.
Yes.
Antra, is it Antra? Antra is phenofibrate. How can we use that?
No.
See,
Antra is either.
in our India, Antra is we are getting
DMPA.
for this DMPA we are getting by this name also, and Depo-Provera also, yes, different brands. So yeah, in their country, Antra is used as a, see, one more knowledge we have got it. They are
Yes.
using for lowering the cholesterol level. Of course, the
Okay.
phenofibrate is used for lowering the cholesterol level. Huh.
So
that
here, sir, means Dr. Sheikh, here we are using what rightly Ritu madam said is that this is for a depot preparation of DMPA, and this we give to the woman, and for after 3 months she can come. And but only one thing is with Antra is that she will get a intermittent spotting for that,
Yeah.
But,
Intermittent spotting, and once we stop the injection also, sometimes there is delay in the menses.
Reversibility of the menses.
Yeah. So
but some
1,000
people
times
they are very happy.
patient call every day, Rajeshri, ma'am, कितनी बार मैं urine test करूँ? This is the, this is that thing. So, Dr. Sheikh, if you are there, if you can tell us that what method you are using in your place, that will be great. So we can discuss little bit about that also. Sorry, again my screen is getting blurred. मुझे नहीं पता क्यों ऐसा हो रहा है.
कोई बात नहीं.
मुझे
you are audible and looking nice.
हाँ, मुझे नहीं दिख रहा है. मुझे अब आपका चेहरा भी नहीं दिख रहा है. ब्लर हो रहा है बिल्कुल.
कोई बात नहीं. Dr. Sheikh is there in chat. Somebody has posted.
नहीं, we will see. नहीं, अच्छा, in chat तो Jayashree has. Yeah, she has written. Okay.
Possible because we are using that.
Yeah. So that's with that we will wind up, Rajeshri, because
Yes,
there are no
yes,
more
yes,
questions. Yeah.
yes,
Thank
yes.
you once again for taking out your time. And thank you, Sahiti, and thank you, Shil Pharma, for providing the platform. Sahiti, I request you please show the certificate of appreciation.
Yes, ma'am.
Yeah.
Saiti, 1 minute. I thank you so much, Dr. Ritu ma'am, and she's a wonderful friend of mine, and lots of the things where you can learn from her, and she's a very finest of the IVF specialist of the globe also, and literally her hunger of spreading the knowledge is the very appreciable, commendable, and too good. वो दुर्गा माँ का पूजा करके है बट वो आई थिंक शी आल्सो worships like सरस्वती means the goddess of the
Thank
knowledge and
you,
all,
Rajeshri.
and it
Thank
is
you.
very very important. And Ritu, you are doing a very wonderful work, and so many youngsters they join because what knowledge we are getting is only through the either the books and all. So this is the only one field I always tell to my juniors or the students that you cannot take this degree with the email and all. Na? There are so many courses where you can take the degrees like that, but for becoming a doctor you need to be a dedication, very much sincerity, and you have to update yourself till your last practice days and all. So you
Yeah.
have done a lots of great contribution to the field of medicine. This is with this all this platform. Hats off
तुम्हारे जैसे
and
दोस्तों का
thank you
साथ
very
है
much.
राजश्री,
Yes.
और माता रानी की ब्लेसिंग्स है. हाँ हाँ.
नहीं, नहीं, बहुत
So
अच्छा, क्योंकि अच्छा
हाँ
नॉलेज मिलना, लोगों को ऐसा प्लेटफॉर्म देना टू टेक अ
हाँ हाँ.
टाइम फॉर दिस फ्रॉम योर ओन प्राइवेट प्रैक्टिस. It is wonderful job and many good speakers because she is the wonderful friend. So all of they do join and do this work, this noble work very nicely. So thank you very much, Ritu. You are very
Thank you, dear. Thank you, my dear. Huh. See, now doctors are still joining. So
yes.
this is a certificate of appreciation from our side to Professor Dr. Rajeshri Katke for
Thank you, sir.
contributing as a distinguished speaker for 31st July session. So really, we are grateful to you.
And thanks to all of the audience, and thank you so much across the globe. The doctors has been joined and enlightened with their experiences to us. Thank you very much for all of you also. God bless
Thank
you
you,
all.
thank you. Thank
And
you, friends.
good night, India.
Good night. Good night,
Comfortable.
everyone. Thank you. Thank you.